Hi everybody, my name is Samantha Wagner and my presentation is about insomnia disorder 780.52 or G47.00. For the diagnostic criteria, it's a predominant complaint of dissatisfaction with sleep quantity or quality associated with one or more of the following symptoms. Difficulty initiating sleep. In children, this may manifest as difficulty initiating sleep without caregiver intervention, difficulty maintaining sleep, characterized by frequent awakenings or problems returning to sleep after awakenings. In children, this may manifest as difficulty of returning to sleep without caregiver intervention, early morning awakening with inability to return to sleep. The sleep disturbance causes clinically significant distress or impairment in social, occupational, educational, academic, behavioral, or other important areas of functioning. The sleep difficulty occurs at least 3 nights per week. The sleep difficulty is present for at least 3 months. The sleep difficulty occurs despite adequate opportunity for sleep. The insomnia is not better explained by and does not occur exclusively during the course of another sleep-wake disorder. The insomnia is not attributable to the psychological effects of a substance. Coexisting mental disorders and medical conditions do not adequately explain the predominant complaint of insomnia. And you want to specify if it's with non-sleep disorder mental comorbidity, including substance use disorders, with other medical comorbidity, with other sleep disorder. And you also want to specify if it's episodic, so symptoms last at least 1 month but less than 3 months, if it's persistent or symptoms last 3 months or longer, or recurrent, 2 or more episodes within the space of 1 year. Insomnia disorder may occur independently or during the course of another mental disorder or medical condition. Different manifestations of insomnia can occur at different times of the sleep period. Sleep onset insomnia is difficulty initiating sleep at bedtime. Sleep maintenance insomnia is frequent or prolonged awakenings throughout the night. Late night insomnia is early morning awakenings with an inability to return to sleep. The most common single symptom of insomnia is difficulty maintaining sleep, followed by difficulty falling asleep. The most common presentation overall is a combination of these symptoms. Specific sleep complaints vary over time. Individuals who complain of difficulty falling asleep at one time may later complain of difficulty maintaining sleep and vice versa. Some complain of non-restorative sleep, which does not leave the individual rested upon awakening despite adequate duration. When a complaint occurs in isolation but all diagnostic criteria are otherwise met, a diagnosis of other specified insomnia disorder or unspecified insomnia disorder is made. Insomnia disorder involves daytime impairments as well. This includes fatigue and daytime sleepiness, cognitive performance such as attention, concentration, memory, and manual skills, and mood disturbances such as irritability, mood lability, depressive, or anxiety symptoms. Insomnia disorder is the most prevalent of all sleep disorders. Approximately 1/3 of adults report insomnia symptoms, 10% to 15% experience daytime impairments, and 6 to 10% have symptoms that meet criteria for insomnia disorder. Insomnia is a more prevalent complaint among females than among males, with a gender ratio of about 1.44 to 1. Insomnia complaints are more prevalent among middle-aged and older adults. This is partly explained by the higher incidence of physical health problems with aging. Although insomnia can be a symptom or an independent disorder, it is most frequently observed as a comorbid condition with another mental disorder or medical condition. For example, 40 to 50% of individuals with insomnia also present with a comorbid mental disorder. Insomnia symptoms can occur in children and adolescents. There's limited data for this age group, but from the few small studies conducted, researchers found that insomnia is associated with behavioral and emotional problems such as depression, anxiety, conduct problems, suicidality, poor academic performance, and poorer health. In addition, sleep problems may be associated with negative outcomes over time. Sleep difficulties in childhood can result from conditioning factors, such as the presence of a parent in the bedroom or inconsistent sleep schedules and bedtime routines. The onset of insomnia symptoms can occur at any time during life, but the first episode is more common in young adulthood. In women, new onset insomnia may occur during the birth of a new child or menopause and may persist even after other symptoms have resolved. Insomnia may have a late life onset, which is often associated with the onset of other health-related conditions. Insomnia can be situational, persistent, or recurrent. Situational insomnia usually lasts a few days or weeks and is often associated with life events or rapid changes in sleep schedules or environment. It usually resolves once the initial precipitating event subsides. Some individuals may be vulnerable to sleep disturbances, which can lead to persistent insomnia symptoms long after the initial event. Factors that precipitate insomnia may differ from those that perpetuate it. In some cases, insomnia may also have an insidious onset without any identifiable precipitating factor. Recurrent episodes of insomnia are often associated with the occurrence of stressful events. Even when insomnia is chronic, there is night-to-night variability in sleep patterns. Also, the characteristics of insomnia may change over time. Insomnia symptoms change as a function of age, so young adults may find it harder to fall asleep, and as they get older, their problem becomes maintaining sleep. Sleep disturbances are more likely to occur when predisposed individuals are exposed to precipitating factors, such as major life events or less severe but more chronic daily stress. Most individuals resume normal sleep patterns after the initial triggering event has disappeared, but those who are more vulnerable to insomnia continue to experience persistent sleep difficulties. Insomnia is often associated with psychological and cognitive arousal and conditioning factors that interfere with sleep. The more the individual strives to sleep, the more frustration builds and further impairs sleep, and this becomes a vicious cycle. Some acquire maladaptive sleep habits and cognitions which facilitate this cycle. This includes excessive time in bed following an erratic sleep schedule, napping and fear of sleepiness, a fear of daytime impairments, and clock monitoring. In terms of temperament, anxiety or worry-prone personality or cognitive styles, increased arousal, predisposition, and tendency to repress emotions can increase vulnerability to insomnia. Environmental factors such as noise, light, uncomfortably high or low temperature, and high altitude may also play a role. Females and older individuals have an increased vulnerability to insomnia. Insomnia also displays a familial disposition, so the prevalence of insomnia is higher among monozygotic twins compared to dizygotic twins. It's also higher in first-degree family members compared to the general population. The extent to which this link is inherited through a genetic predisposition, learned by observations of parental models, or established as a byproduct of another psychopathy remains undetermined. Insomnia is definitely a global issue. It's important to note that the ICSD-2, which is the diagnostic manual from the International Classification of Sleep Disorders, and the ICD-10 vary in their approach to defining insomnia. Thus, prevalence rates vary internationally and range from 10 to 40%. One recent study found prevalence rates in Denmark and Italy were 16.6% and 31.2% in Poland. Another study looked at individuals from 8 countries in Asia and Africa and found a prevalence rate of 16.6%. There's various theories associated with insomnia disorder. Stimulus control perspective is based on the principles of instrumental conditioning and was introduced by Boutsen and Nicasio in 1972. Individuals with insomnia usually spend large amounts of time in bed itself, engaging in non-sleep related behaviors like reading, watching TV, working, spending time on the internet, or worrying. This leads to stimulus discontrol, which is the reduced probability that sleep-related stimuli will occur in association with sleepiness and sleep. Thus, the repeated pairing of bed and the bedroom with the physiologic and neurobiologic state of wakefulness makes it likely that these stimuli may become conditioned for wakefulness rather than sleepiness. The three-factor model is also referred to as a Spielman model. This theory posits that insomnia occurs acutely in relation to both predisposing and precipitating factors. Predisposing factors include individual traits such as hyperarousal, the tendency to worry, and social factors such as sleep schedules between bed partners or pressures during child rearing. Precipitating or life stress factors are acute occurrences that trigger sleep continuity disturbance, and this can range from life events to medical and psychiatric illnesses. The theory also posits that chronic insomnia is a result of maladaptive coping behaviors or perpetuating factors, and perpetuating factors refer to the behaviors adopted by the individual, which are intended to cope for sleep loss. One of these behaviors is known as sleep extending, and this is the tendency to compensate for sleep loss by napping, going to bed earlier, or sleeping later than normal in an effort to recover what has been lost. In reality, this leads to the dysregulation of sleep homeostasis, which perpetuates insomnia symptoms. The neurocognitive model is an extension of the Spielman model. This model is based on the pluralistic perspective of hyperarousal, which is that hyperarousal may exist within several domains, including the cortical, cognitive, and somatic domains. In addition, it supports the notion that sleep initiation and maintenance problems don't occur because of the hyperarousal per se, but because of increased sensory and information processing. And the cognitive perspective proposes that worry has a central ideologic role in the precipitation and perpetuation of insomnia. Any event or disease process that gives rise to intrusive thoughts or rumination can inhibit the initiation and or maintenance of sleep. It's also related to dysfunctional beliefs, specifically about sleep, which perpetuate insomnia symptoms. More recently, the cognitive model has been expanded to include information processing perspective, which suggests that, along with worry, insomnia occurs in association with the way people perceive, remember, and respond to events related to the experience of insomnia. Some may have selective attention to internal and external stimuli in the environment, and this can be automatic, and it can reinforce monitoring behavior, which perpetuates the insomnia. The word insomnia was first added to the dictionary in 1623. In Latin, in means not, and somnus means sleep. Although there is little data on the origins of insomnia disorder, people have experienced sleep difficulties throughout time. In ancient Greece, they put a lot of emphasis on the restorative power of sleep, as well as the balance between sleep and wakefulness. The beginning of the modern approach to sleep research was in 1913. Henry Piron published a book that examined sleep from a physiological perspective. In 1920, American scientist Kleitman questioned the regulation of sleep and wakefulness and of circadian rhythms. He's now known as the father of American sleep research. In 1953, him and his student made the landmark discovery of rapid eye movement during sleep. And in the 1960s, Henry Gusteau led investigations on the sleeping brain and the body's vital functions. This type of work eventually led to the new discipline of sleep medicine. There was a significant shift in the definition of insomnia from the DSM-4 to the DSM-5. The criteria was changed in that symptoms must be present for 3 months, as opposed to 1 month, and it was changed from insomnia to insomnia disorder. More importantly, the DSM-5 removed primary and secondary categories of insomnia. Primary insomnia is sleeplessness that is not attributable to a medical, psychiatric, or environmental cause, whereas secondary insomnia is when symptoms develop as an underlying medical, psychiatric, or environmental cause. This was seen as a paradigm shift that stresses the comorbid nature of insomnia. In 2017, Otzelek and Young discovered the insomnia gene. Mutations in CRY1, one of the genes responsible for controlling the biological clock, could cause deteriorations in biological rhythm and the sleep cycle. Assessment begins with obtaining a detailed history from the patient. The clinician should evaluate the nature of the complaint. Is the patient having difficulty falling asleep, maintaining sleep, waking up early, or could it be a combination? The interview can help guide the diagnosis, as the insomnia may be resulting from another condition or another sleep-wake disorder. The sleep-wake diary is an effective way for the patient to keep track of their sleep habits. In the morning, the patient fills out things such as what time they went to bed the night before, what time they got out of bed in the morning, and how difficult it was to fall asleep. At the end of the day, the patient fills out how many caffeinated drinks they consumed, if they took a nap, their mood, and things like that. Keeping a sleep diary can be informative as to what is keeping the patient awake and can identify bad habits. Actigraphy is a procedure that records and integrates the occurrence and degree of limb movement activity over time. Devices can be worn on the wrist or ankle over a period of days to weeks. Mathematical algorithms are then applied to the data to estimate wakefulness and sleep, which can show patterns over time. However, it cannot provide estimates about stages of REM and NREM or information about respiratory function. The gold standard of sleep assessment is polysomnography. This is a test used to diagnose sleep disorders. It should really only be used when the patient has exhausted all other treatments. It records brainwaves, oxygen levels in the blood, heart rate, breathing, and eye and leg movements. It basically monitors sleep stages and cycles to identify if or when their sleep patterns are disrupted and why. This is usually done at a sleep disorders unit within a hospital or sleep center. For differential diagnosis, this includes normal sleep variations, situational acute insomnia, delayed sleep phase and shift work types of circadian rhythm, sleep-wake disorder, restless leg syndrome, breathing-related sleep disorders, narcolepsy, parasomnias, and substance medication-induced sleep disorder, insomnia type. For treatment, treatment of insomnia has 2 primary objectives: improving sleep quality and quantity and improving daytime impairments. CBT interventions include stimulus control therapy, relaxation techniques, sleep restriction, remaining passively awake, and light therapy. It can also include pharmaceuticals, so benzodiazepines, which includes Halcyon, Ativan, Restoril, or Doril. Non-benzodiazepines includes Lunesta, Sonata, or Ambien. Ramultion, antidepressants including doxepin, barbiturates, and melatonin. Also, some individuals will take over-the-counter medications such as Tylenol PM, Benadryl, Unisom, or other sleep time aids, but doctors only recommend short-time use for those. Also, healthy lifestyle changes include going to bed when you feel tired, avoiding